Excellencies, colleagues, dear friends and fellow champions of health systems, it's a privilege to join you today, even virtually, for this inaugural Science for Health Systems Conference. I sincerely thank Professor Margaret Crook and the Quest Network for organizing this timely and essential dialogue on innovations in quality and performance measurement for the well-being of the global health and humanity. Across Africa, we are witnessing a pivotal moment in health system reform. The COVID-19 pandemic and a series of increasingly public health events such as Mpox, cholera, Marburg, Ebola have exposed vulnerabilities in health systems, but in turn has driven innovation, resilience, and change. To ensure health sovereignty in Africa, we are focusing on data, digital transformation, and research leadership. Data among other strategic components. Evidence is more than just data. It acts as the compass guiding reform, the foundation of accountability, and the link between policy and impact. Evidence is not about numbers on a spreadsheet. It's about whether a mother survives childbirth, whether a child gets a vaccine on time, and whether a pandemic is detected early. Data and quality are the guarantees that every dollar, every worker, every innovation delivers real impact. In 2024, only 38% of Africans' population has access to reliable internet connectivity. This digital divide limits our health system ability to function in real time and denies community health workers the tools they need to save lives. I'm proud to announce that Africa CDC is signing a landmark agreement with Starlink that will extend connectivity directly to community health workers and strengthen linkages with national health systems. This isn't just about technology. It's also and more about equity, access, and ensuring that no community is left behind in the delivery of health systems across our continent. Excellencies, dear colleagues and friends, let us use this conference as an opportunity to challenge assumptions, to exchange innovations, and to propose practical, evidence-based actions that improve performance, ensure sustainable progress, and enhance lives and livelihood. We need evidence to allocate resources fairly and effectively, generating tangible results and impact. Most importantly, we must use the evidence available and interpret it impartially, free from personal bias, and we need to make that as a way for global decisions. Let me thank all of you for your attention and wish you successful deliberations.
And as the discussants are coming, I loved what Dr. Kaseya had said, welcome health system champions. I went to the University of Notre Dame, which is renowned for its football program, and every time the players go out onto the field, they tap a sign before and it says, play like a champion today. So we're gonna play like health system champions today. Go Irish. Okay, so thank you very much for being up here, and we'll perhaps go in the order in which Dr. Lewis introduced the panelists. So I'll start with Dr. Siddiqui, and the same question for the other panelists is, what is a theme that you heard in the recorded message from Dr. Kaseya that resonates with you and reflects upon the work that you do? Dr. Siddiqui, please.
Thanks very much. Good morning to you all. So I think what came out strongly with the brief intervention from the colleague from Africa was around data, and I think this has been resonating and this has been reverberating over the last couple of days. And the perspective that I see from a data is that, in our countries, while there will always be research and surveys, but strengthening information systems will be critical for use and then decisions, basically. And I would like to bring out two kind of challenges from my experience and then some achievements as well, very briefly. So one of the big challenges that I see in our countries is the fragmentation of these information systems. We are responsible, but partly also our development partners, the Global Fund and Gavi, they all want to have an information system for TB and HIV and malaria and so on and so forth. And I think that leads to a lot of fragmentation. So I think that's a gap that has to be addressed. And as we digitize our systems, we may end up with multiple systems. And somebody didn't like the word interoperability, but that is certainly a challenge in my country. The second one, I think, is the lack of data that we have for what happens in the private sector, at least certainly Mike, and many countries in South Asia for that matter. We really don't know what is happening. Our information systems do not necessarily capture what is happening. And I think that's a gap. Many countries, people, first point of contact is not the public sector, it is the private sector. So I think those two would be my challenges that I would like to sort of bring in. But on the more positive side, I think you saw the presentation that you gave, the slide that Tracy you presented, is the use of data for monitoring purposes. And I think that's a very positive development that is certainly happening. And the other one that I'd like to touch on is that one of our big provinces, which is Punjab, which has 125 million population, has moved towards the establishment of an electronic medical record system, which I think in a resource constraint setting is a very big achievement. It has challenges, it's not of great quality, but I think it's a very good step forward. And I just want to leave you with one figure. So the antenatal visits in the province in the year 2023 was 7.5 million. And that's big data. And that's the kind of data where we need to improve the quality, and we also need to be able to handle and analyze it for our decision makers for better use and informed decision making.
Thank you, Dr. Siddiqui. Dr. Roda-Dewan, and after the panelists speak, we will have a Q&A session, so get your questions for this great panel. Dr. Roda-Dewan.
Thanks, Mark. So I have a minute, but I think listening to Dr. Kaseya makes me appreciate the creativity and innovation that comes from being faced with really serious challenges, and you see that in sub-Saharan Africa, and he raised several of the examples, the responses to that. I've had the privilege of working on service delivery redesign for almost a decade now, and just in the last few years have kind of transitioned to using a service delivery redesign lens for maternal and newborn health in the US, where we have the worst maternal health outcomes, birth outcomes in general, among our high-income peers. The situation appears to be getting worse and is happening against a backdrop of steadily closing labor and delivery units. So in my state of New Hampshire, we've lost 11 of the 26 labor and delivery units. So really a backdrop that can be, I think, overwhelming and depressing. But what I'm learning about the response here in the US, similarly to sub-Saharan Africa, is that by listening to patients especially, and taking that input seriously, and thinking creatively and outside of the box, innovations and solutions are possible, and even possible at a structural level. So, for example, the state New Hampshire has now adopted reimbursement for doulas. And in listening to our patients, we've learned that it isn't enough just to have this really highly effective intervention available in general, but that people want doulas that look like them, that understand their background. And so our program in New Hampshire uses a community health worker model, actually very familiar in the global setting. But it's being adopted here. So we have doula/CHWs who can extend a combination of services to our rural areas. And we have recovery coaches, so folks with lived experience of substance use, for example, functioning as doulas. So grateful for the opportunity to say a few words. Thanks,
Great.
Mark.
Thank you, and connects with the connectivity theme that Dr. Kaseya had mentioned. Okay, Dr. Allen, over to you, please.
So I really loved that Dr. Jean, they're facing incredible challenges in the Afro region, but he's so positive. And Margaret asked us to reflect on in our own regions, what are the positives that we can be looking for? And I was reminded this morning of the words of Machiavelli, who said, never let a good opportunity, never let a good crisis go to waste. And we need to be looking for the opportunities, even in the toughest of times. And I think what we saw in Europe with COVID and coming through that period was that the opportunity we took there was the population got much more used to and comfortable with novel models of care, which enabled us to be a lot more efficient in the way that we use particularly our workforce and the way that we connect with people in rural areas. And reflecting back on the last 10 years that I've been a family doctor for as well, at the beginning, I could send text messages to my 75-year-old patients, but they wouldn't text me back. But literacy is improving as populations are aging. That comes with lots of other challenges as well, but it allows me to be a lot more connected with my panel of older patients than I ever have been before. And that's true across the European region as well. As we're thinking now about, oh my gosh, what do we do with multimorbidity and this aging, ballooning population, and we don't have enough family doctors and we can't train them fast enough. And in the UK, for every 5 GPs that are trained, 4 leave the workforce. So you've got to train 6 to add 1. The current model doesn't work. And so what do we do about that? Actually, it's bringing in allied health professionals and using this moment as an opportunity to move towards multidisciplinary teams. And the population's going with us because things are changing and they understand that finances are stretched. And 80% of people think that the system needs to be fundamentally rebuilt. That's an opportunity for people like us to put forward policy solutions because the Overton window is expanding. So it's a very, very challenging time in Europe and elsewhere, but actually it's a time of great opportunity as well.
Thank you, Dr. Allen. So last but not least, Dr. you're out there.
Thank you. Listening to Dr. Kaseya, I see clearly that Latin America and the Caribbean face the same challenges, especially in terms of quality and equity and use of evidence. I think in Latin America, during the last decades, we have achieved a lot and we have pretty good averages, I would say. But in terms of equity, we see the gap with those that have been left behind. So from the Inter-American Development Bank's perspective and looking at that in the next years, our strategy to support countries in Latin America is to improve, to decrease the equity gap, to improve quality and improve efficiency. We see the opportunity of working with a system perspective on how to support the countries, not for vertical programs, but to work on how to have a high performing system. And so I think this is an opportunity for us to learn from all of you, from the African continent and from others, how to do this. Because I think at this point, we all have the need clearly identified. And we know the elements of the high-performing system, but how can we do this in a very integrated way from the science of implementation perspective? And it's not easy. We have tried this with Salud Mesoamerica, which is a multi-donor, multi-country, multi-stakeholders initiative. And we have a lot of learnings, but we also understand the challenges that we have to incorporate a system perspective in a high-performing system goal. So one of the components of this that I think we all share, not only with the African continent, is the issue on improving the quality and the opportunity of the data, and more importantly, how the research needs to be linked to the implementation, the actual needs of the country, and how this is going to be. We need to assure that the research is being used and will be used for implementation towards getting results, outcome level results and impact results in health. And also we all need to be more flexible to discuss the research questions as we have been discussing here and hearing from different researchers, and how this need to be aligned to national priorities, but also to the funders' priorities. Trying to understand that this is a process of negotiation and compromising on what is needed from different perspectives. As well, how to be tolerant to failures and to changes in adaptability and flexibility while implementing something like getting to high performing system or in research. So I think we have a great opportunity. I think for Latin America, this is a turning point in which we should focus more on quality and high performing system instead of only coverage, which I think we have been doing well so far, but as we know, that's not enough.
Thank you very much. So I heard this connectivity throughout, thinking about evidence connecting not only for health system performance, but data and being connected to health systems to improve equity, access, quality, and ultimately for impact. I mean, that's why these systems are designed. They are self-organizing. They're going to be systems whether we're studying them or not. They are complex adaptive systems that are changing all the time, whether we're studying them or not. And the trust that end users have in those systems is going to depend ultimately on the encapsulated interest. Does the system care for those for whom it's supposed to care? So now we've got some time for Q&A, so I'd love to hear from you all out in the audience, some questions related to the panel. So while you're thinking about some of your questions, what do you think about this role of trust? I don't know who wants to be taking this. This is one of these things, it's a latent construct, it's hard to study, we know how to break it, it's much harder to build it back up. Maybe you can talk about activities that you think are helping improve trust in where you work.
I can just start. So trust is key, and since I also referred to the private sector, I think that trust is lacking sometimes between the public and the private sector, and that is something that needs to be built up very much, because with that kind of partnership, I think we can achieve a lot more. I also want to touch on the subject, on the term of universal health coverage, and I think it's worth spending 30 seconds, because we've been talking of health systems, but health systems for what and strengthening for what? And I think the way it resonates much better with policymakers, in my experience, is when you say, when you're talking of some achievement in terms of a goal or a target, and that's universal coverage. So we have been working for systems for decades, and I think we were not able to sell it as much when we changed the lingo or the phrasing from health systems towards achieving universal health coverage. And that's where I think partnership and trust is critical. And I think certainly involving the development partners, the private sector, and all of the stakeholders will be critical to be able to achieve that particular target, which is a pretty ominous target for many of the countries.
Thanks, Dr. Siddiqui. I think the Edelman Trust Barometer has demonstrated that business is actually the highest, has the highest level of trust NGOs previously had, but things have changed. Things have changed. While trust in institutions has broadly declined, there are places where trust is still, the leader. Now that will change over time, I imagine too, as long as businesses, how they operate and act. Will they continue to maintain that trust, or can they grow it? Dr. Iriarte.
I think that the intent of building trusted relationship is not enough. I mean, sometimes we think that it's enough thinking that we will talk transparently and honestly and bring our ideas. And in reality, that needs more than intention, like a planning and having a real strategy on how to build trust. Because it's something that needs time, but it pays off after, when we really are able to discuss problems and solutions and put our cards on the table in terms of financing, resources, and abilities, competences, and limitations. So also understanding what battles can be won and which ones cannot. Yeah, this is really important. I have found that when at least we have one or two stakeholders that would like to go through this path of building trusting relationships and having some support on how to do it strategically with some activities that are needed to do that. It's not like it's gonna come out by magic, yeah? And having a very clear, like, how success will look like if we think that we are building a trusting relationship. We have had some experiences on that with countries, with donors, and the IDB, different units and departments. And it took us during our first initiative, like around, for all of us, donors and countries and everything, like about 1.5 years to come from looking the best ourselves in front of the other to discussing really problems and lifting barriers and co-executing and working shoulder to shoulder and being accountable to each other.
Yeah. I mean, you're saying that it's not just a calculation that's happening. There's an emotional component, a psychological state, trust is, and there's some vulnerability there, particularly when you're sharing when things aren't always the best. Dr. Rododewan, then Dr. Allen, and then make sure you raise your hand and I'll call on you too.
I mean, I think in the US we have a real crisis of trust when it comes to maternal health right now. You know, we've been talking about bias in maternity care for decades, but our Black mothers are still not being treated the same as others. And I have a pretty simple approach to thinking about trust in this setting. I think if we deliver quality services that meet people's needs, they will trust us. And I think this builds a little bit on what you're saying, Dr. Iriarte. I don't think of it as a separate concept. I think it's very closely tied to the performance of our health systems and our ability to deliver care that meets people's needs.
Thank you. Dr. Allen.
Yeah, just to bring in my personal experience as well in this place, where we've seen that disconnect where people don't trust the health system, but they do trust their provider. And the way that's played out in, probably for most of us, is the rise of populism around vaccines and the politicization there. And so lots of our patients in our practices no longer trust the system, but they do trust us as their care providers. And so the approach to then getting vaccines in their arms is much, we can't have public health independent of primary care. We need to have the two working closely together, the delivery coming through primary care, and thinking much more about outreach into communities rather than people coming to us, that kind of static, reactive model, being a lot more proactive in what we do, segmenting our populations. And so we started hiring community health workers in Oxfordshire, which is a relatively novel intervention in the UK. Because the final two things I wanted to say on this is that trust is earned and trust is relational. It's not a thing you can do. It's very hard for a public health agency to get people to trust it. It's through networks and it's through healthcare workers in the community relating to individual patients. And I think we need to be targeting those who are most at risk of missing out on their screening and their mammograms and everything else.
Thank you. Yeah, some of the 3 C's of trust is competency, character, and caring. Institutions don't love you back, so to speak, and it's the people who do that caring and loving for you that I think is essential. I completely agree. It's you know, visit by visit, interaction by interaction, and that's how it builds.
One other thing about that, which is a challenge that we face, is the old model was that you'd see one provider. The new model is, and they had a vocation, right? They'd become a nurse, they'd become a GP, a family doctor. Increasingly, people they're a GP or a nurse and it's a job for them. And also the roles become a lot more transactional. Like if you're relating to your GP via a chatbot or a text, it's a very different dynamic. And actually you don't have the same kind of relationship. And if you're not seeing them for your asthma monitoring and your blood pressure because you see the nurse and your bloods are done by somebody else, you might have relational continuity with a team, but it's not one individual. So actually we've just got to be cognizant of the fact that we're actually diluting relational continuity with the introduction of multidisciplinary teams. So there are trade-offs there that we need to be really sensitive to.
Yeah, and dilution with technology. We shouldn't cede too much to technology too quickly, because even taking the history, there's something in the listening that I think is really important as a physician. Okay, if we don't have questions from the audience, oh, someone's got one. Zainab's pointing me, so I can't see very well. Oh, yep. Dr. Mahmood? One question.
Good morning, everyone. I'm Zainab Mahmoud, a cardiologist here at WashU. My question relates to global health. Oftentimes, progress is driven by these global health goals. And I work in maternal cardiovascular health, where a target is maternal mortality. And oftentimes, these are goals that are already achieved by high-income countries when we set the targets, and they seem too ambitious for low-income countries. So what do you think, how do we speak the same language when we try to improve progress and measure performance across health systems in different contexts? What is the best way to set those targets?
Tough question. All right. Dr. Rododewan, this is closest to your work, so I'm going to put you on the spot.
I think I'm a little black and white about this, honestly. I don't think that we should have different targets for different settings. I think from an equity perspective, it's hard to say that it's okay for a woman in a lower income setting to, receive less care during her antenatal visits than one in a high income setting. I've also experienced how complicated that can be when your targets are very ambitious and in a low-income setting. And I think that conversation really needs to be around sort of setting milestones towards the ambitious target. But personally, I feel very uncomfortable with changing the targets depending on the context. I think people deserve the same quality of care across the world. So.
Any other panelists on?
It's simpler when you use relative targets rather than absolute targets. So, for instance, with the NCD targets, it was to look for a 30% reduction, relative reduction, rather than you must reach a certain rate, because then everyone's on a same playing field, irrespective of where you've started from.
Well, I keep hearing the buzzing, so that maybe that's our clue for us to wrap up. I'd just like to thank the panelists and Dr. Kaseya for his prepared remarks. Thank you all for being here, and we look forward to the next session. We're going to hand it back over to Dr. Crook.
All right, everyone. We are slowly but surely drawing to a close of this incredible gathering. What we're going to do next is have our closing panel, the final panel, final exchange of the conference, and then some closing remarks from Vice Provost McKay. So let me just make a few comments before I invite our panelists up for this conversation. We have spent the last 3 days speaking broadly about the opportunity before us, for sure the challenges, there's no hiding from those, but also the opportunity before us. And I was so inspired by Dr. Kaseya's message. If we think about all the continents right now that are facing a challenge in health systems, in health system financing, in health system support, global support, it is the continent of Africa that is perhaps the hardest hit. And what struck me in his remarks is the tone of optimism that came through so loud and clear. Dr. Kaseya is not waiting for a handout for others to come to the rescue. He's moving ahead, and he's moving ahead, he mentioned, with a public-private partnership, with reconceiving what health systems can be and can do and whom they can work with. And I just found that incredibly inspirational, because if he's not complaining, we should not be complaining, right? We should be looking for the opportunity. So a couple of the themes of the conference so far that I would like for the panel to reflect on with us. We've dedicated a portion of this conference to measurement. And I think what we know and what we all sense strongly is that measurement needs to be for a purpose. Yes, it must be lean, it must not be overwhelming, but it must be nuanced enough to pick up on longitudinal care, to pick up on paths that people actually take through the health system. And to do this well, we need to work with actors, and that would be users of the system and patients, as well as providers, right? Because if they don't understand or value measurement and give input onto what the measures should be, then it just becomes a burden and actually not helpful. We heard so much, including in the last panel, about the incredible innovations in the development of EMRs in a country still struggling with poverty. But I was shocked at the amount of ingenuity and technology that was put to digitalizing patient records in Punjab when I visited a few months ago. It was a command center that was tracking facilities throughout this massive region. Okay. So we need to cast off our preconceived notions of what is possible in any country, including lower income countries, because every day they're showing us that much more is possible than we thought. Measurement really matters. Improvement. What have we learned about improvement? Improvement is not about tweaking. It's not about tiny adjustments. All right, maybe if everything's working perfectly and your costs are low, your outcomes are high and your patients are thrilled, that's a moment for tweaking. I did not hear that was the situation in most of the countries that we are coming from. I heard, including from the People's Voice survey, that there is a need for transformation and a thirst and a hunger for transformation. But how do we transform? Well, that doesn't come just from evidence. That was pretty clearly stated, I would say, in this meeting, right? It demands political courage, actually, to start with, and a kind of commitment to the ultimate goal of the health system, which is health. And this is an opportunity also to reflect on another comment of Dr. Kaseya's, which is that he said, and these are his words, we need evidence to allocate resources fairly and effectively. That's precisely the mission statement for health systems research. The evidence to help us allocate resources fairly, but not just fairly, but effectively, right? Because we have no money or time or lives to waste. So effectiveness and making sure that our approaches, our improvement strategies are really going to be effective, not just pretty, not just shiny, but effective, is critical. And so I think there we've talked a lot in this meeting, and a key theme of this meeting was the value of comparison. Maybe we don't need to invent our own approach. Perhaps the UK's tried it, or Punjab's tried it and found it to fail. Perhaps somebody has thought of an innovation that would really make sense here with adaptation. It's not the health systems are the same everywhere. We would never claim that. But we think there is far more opportunity for generalizable knowledge to be shared across systems than we have taken advantage of up to now. And that, I think, is a tremendous opportunity for system science, health system science going forward. I would think that at this moment, the central challenge emerging from this conference is that we're at this liminal moment. We're kind of on this edge. And the question is, does this fault line signal rupture or a space for renewal? And how do we adapt our research questions as well as our research methods for this new set of opportunities? And I refuse to see them as challenges alone. These are new opportunities. Health will always matter. You heard Dr. Galea say this. Health is the one thing that unites the parties and ethnic groups and countries. It will always matter. And therefore, health systems research will always matter. But we have to do it better. And we have to do it better from the question perspective, a methods perspective, but also a meaning and translation perspective so that the knowledge doesn't stay in journals, right? We heard a lot about that from Dr. Figueras and others. And with that, I would like to introduce the panel, bring them up here to help us dive into these themes and help wrap some of these concepts together. So let me, in some cases, introduce, and in other cases, reintroduce our panelists. Dr. Patricia Garcia. She's professor at the School of Public Health at Universidad Peruana Cayetano Heredia, an adjunct professor at the University of Washington. She has served as the Minister of Health of Peru and is a longtime member of Quest Latin America Network. Welcome to you, Patty. Dean Sandra Galea, the Margaret C. Ryan Dean of the School of Public Health, and the Eugene S. and Constance Kahn Distinguished Professor in Public Health at Washington University, works and is recognized globally for his work on the social causes of health, equity, and population well-being. And in the remaining time he has, he's also the dean of the inaugural dean of the new School of Public Health at Washington University. I would like to welcome up Dr. Andwele Jolie. Dr. Jolie is president and CEO of the St. Louis Integrated Health Network. It's a nonprofit organization connecting patients and health systems to strengthen the safety net providers, the organizations that really serve our lowest income populations, and to advance equitable care for all St. Louisans. And Dr. Josep Figueras, welcome back up to the stage. You may remember that Dr. Figueras is Director Emeritus of the European Observatory on Health Systems and Policies, which is a partnership supporting evidence-informed policy across the WHO European region through comparative research and policy dialogue. So we have leaders here on the stage from policy, academia, and the front line of health systems to discuss on how we take advantage of this opportunity before us. And let me invite them to make their brief remarks, about 5 to 7 minutes, and talk to us about how we move forward. And I'm going to join you. I don't think anyone has slides, right? We're all, okay, perfect. Okay, so let's start with you, Dr. Patty.
Okay, well, first of all, thank you very much, Margaret. This has been a wonderful conference where we have been able to hear about experiences and discuss a lot about not only science, but how can we really try at least to bridge this gap between research to policy. So one of the things that I would like to talk about is that in global health, usually we talk a lot about this research to policy gap. And one of the problems that I see is that usually we talk about it as if it is a technical problem. And actually, it is a relationship problem, really. And as in any relationship, it has to do also with communication, right? During my life, I had the opportunity of jump from academia into governmental positions. And actually, I was head of the National Institute of Health, went back to academia. I have been the dean, work in research, and then I became Minister of Health, but I guess that allowed me to understand the good, bad, and the ugly of both sides, research and academia, and to be more sensitive about the things that happen. I learned that, and we have discussed these issues, policy is not linear, right? And it's when you work in research, and usually you want your research fundings to become policy and be implemented. The reality is that you come with something that may not be what the policymaker need, or maybe not even the community need. And there is a negotiation that between the evidence politics that takes time and trust. So when we talk about what are the changes that we need to do, not only to be more effective, and especially during this time, I think we need to think about how we do things in a different way. So good evidence, and we have talked about this, is essential, but it will only have impact if it is usable, and it will be usable when it really answers the questions that policymakers have. And in order to do that, we need to work together and embed the research within the health systems and to involve the community and the policymakers in this. I mean, it's much easier to say than do. It takes time, but I think academics and researchers, we all have the responsibility to become more socially accountable, okay? And I think that's something that, and as an example, I think in Peru and I think in Latin America, several of universities have been able to do during the years. We have examples related to maternal mortality. Peru became an exemplar of maternal mortality when we were able to decrease maternal mortality from almost 200 into 68. The government implemented great health services, but nobody was coming. And actually, when they were asking, what should we do and what is going on, then we tried to help and start asking people, and we suggested, let's ask women why they were not coming. And actually, women were scared about these new health centers, and they were scared of going to them to deliver because they had to be laying in a bed, and they were used to have vertical delivery, which means they wanted to be with a family, and they wanted to hold themselves and deliver standing up. And that finding from research, because there was a need, came with a change in policy now in the rural areas, in the Andes, in the jungle, and even in the outsides of Lima and certain cities. We have services that have both options, so they can deliver in the standard way, or women can ask to deliver in vertical delivery, and that has changed everything. But this type of experiences also created a partnership between researchers and policymakers. Took time, but now we have trust, okay? So I think the kind of things that we really need to work on is embedded research on the needs. Listen to the community. Use the different methodologies and multiple methodologies, but also one thing that is really critical is to create the trust that is needed, and to be able to work together, creating, and that's the issue of co-creation, that some people are really scared about it. But actually, I think we, as researchers, we also need to understand that we don't have all the answers, that people may have the answers, policymakers have the questions, and we all together can work to try to make research more useful, and again, be more social accountable and not only academic accountable. I stop there.
Wonderful, as always. Thank you so much, Dr. Garcia. Dean Galea, from your perspective.
Good morning, everybody. Thank you for having me part of this. So it has been really interesting in this meeting to engage with all of you who are health systems expert. I'm not a health systems expert. My lens is one of population health. And I've always, thinking about health systems within the population health realm is almost always once removed, because with population health, you tend to think about all these upstream policies, think about the conditions that create the world around us. And our lens is almost one of keeping people out of health systems, even though we recognize that when people need health systems, you want to make sure you have excellent health systems. So it's with that framing that I think I have been approaching what I've been listening to and learning from in the past couple of days. So 3 observations, if I may, and then there's 3 attempts at answers to the question. So number 1 is the work of creating equitable, affordable, effective health systems is actually really hard. It is actually really hard. It's clear there has been a lot of intellectual energy being put towards it over many years. And the fact that the general framing of this meeting has been that this is not going well really anywhere at the moment shows how hard this is, which in some respects is a bit paradoxical given how much money is spent in it and given the fact that we as a societies, as a world, have many other systems that work and work better. So that's observation 1. Observation 2 is there are universalities here. There are lessons that can be learned across health systems from that where Peru can teach the United States and the United States can learn from Kenya. There are lessons that are generalizable in terms of what people want, and people want certain things that are pretty similar across many health systems. And then lesson 3, which is perhaps not surprising, is while saying there are universalities within these very complex systems, there are also very context-specific issues, that the particular contexts have both cultural needs, but also historical perspectives that are then baked in to give them a very different perspective on what they actually want and expect out of their health system. So those are sort of 3 observations which stuck to me as I'm listening and learning about health systems within a population health science lens. So then flipping then to the question that was posed to this panel, which is how do you think about research going forward and what research might be most effective? So again, framing this within the population health lens and with just 3 simple observations. Number 1 is there is no question that we need to integrate research in this area with the broader scope of population health research, in that health systems do not exist in isolation. And because of, I think, how we do research, we fragment, right? So the health systems crowd, which is you all here, do not intersect with the population health crowd. And the more I listen, the more I think that that's a mistake, because a lot of what's happening in health systems is being driven by the cultural norms, the economic and the cultural exigencies within which health systems operate. And I think there's a lot to be learned by integrating the science around health systems with the science that generates population health in the world around us. And in some respects, that seems to me like a glaring hole in literature, not just in health system literature, in the population health literature, the whole at the intersection of the 2. That's point 1. Point 2 is that there is a substantial amount of work in health system scholarship that is at the very granular space of how do you implement and how do you make complex systems function effectively, particularly complex systems that are dealing with fragile human experiences. I mean, this didn't come up very much, but I often reflect on why is it so much harder to run a health system than to run a burger chain? Well, I mean, there are reasons for that, but surely one of them is that health systems, we're dealing with humans, that they're most fragile and vulnerable. And humans who are more fragile and vulnerable have different expectations of what a particular system does than what we expect from a system that's selling us a burger. So there is such a ripe area here for the science of implementation, which we've heard from many implementation experts in the past couple of days, and WashU has long been a leader in implementation science, in thinking about what it really means to implement effective systems when humans are at their most vulnerable and perhaps least amenable to some of the tools that we've learned from other areas. So that's the second point. And then the third point is, how does one meaningfully learn from cross-national and cross-cultural experiences? And I say meaningfully because I think it's one of those things that we actually pay a lot of lip service to, that we actually say, the US should learn from another country should learn from the US, but we don't really do it. We actually have such an intra-national bias that it's hard for us to export lessons. Part of that, I think, part of it is perhaps an innate nativism that we all have, but part of it, I think, is also that we're not very good at documenting the science behind what happens in these granular implementation efforts in particular countries. People do things happen, but without them being documented, it's very hard in country X to say, oh, let me learn systematically from what happened in country Y and let me apply it. And it just seems like an enormous lost opportunity. So, wrapping it up, I think my three pathways to how do researchers up their game to meet today's needs, which was the question asked here, is number one, I would love to see health systems research integrate with research about the broader world within which health systems live, because I think we're missing key necessary parts of the causal pie that make health systems effective or not. Number two, we need an implementation science of organizations that deal with human fragility. And that is different than how we implement other systems in other complex organizations in our society. And number three, meaningful ways to integrate lessons from other contexts, and I suppose a call for the documentation and rigorous publication of those lessons, without which point three would not happen. Thank you.
Thank you so much. So many extremely pertinent themes, and particularly about the need to situate health systems in the bigger production engine of health. Dr. Joly, over to you to help us think about how do we work with communities to surface some of these answers, and also what research needs to be done from their perspective.
Thank you for the invitation to be here. Thank you for your time and attention. As mentioned, my name is Ndwele Joly. I lead the Integrated Health Network. I sit in the middle of it all. I'm a nonprofit intermediary that has health departments, medical schools, hospital systems, and community health centers and community-based organizations working collaboratively to make sure that communities that have been historically excluded and disinvested get access to healthcare and social services. And within that, one of our main focus areas is community-driven innovation. The intersection of academic partnerships with community members to think about how are we going to solve the disparities within our communities. In the US context, Dr. Kaseya mentioned culture and history, and how that impacts healthcare delivery, especially in the context of the United States, where Black women are 2 times more likely to die in childbirth compared to white women here in the United States. Black infants are 3 times more likely to die here compared to white infants. I, as a Black male, for every minute I walk north of this campus, my life expectancy drops by 1 year. So at the IHN, how do we solve this? We solve this by radically listening to community, especially communities that have been historically marginalized. And so one of our, I'll give you an example of how we walk through in some of the contexts that's similar to Peru around how do we listen, radically listen to our patients. And by radically, I mean allowing them to own their own experience and recognize that they are experts in their experience, and how can we learn from that as a provider organization and as a health system. So one of our community health center providers, a white female, said, I'm tired of my black women and babies dying. How can you help? And the CEO at the time, my predecessor, said, well, let's listen. And what do these women want, black women in the health centers? They wanted, one, for the providers to not have bias towards them, be racist towards them, have context for the trauma and toxic stress to racism. Also, just understanding the behavioral and mental health components that comes with delivering babies in this country, if you're a black woman. Here in the United States, if you're more educated and of higher income as a black woman, you're more at risk for premature birth. In St. Louis, the premature birth rate is about 19% for black women, and about 12% for white women. And so we co-designed, co-created based on what they asked for. And it wasn't them that needed fixing. It was the providers that needed fixing. They also asked for group prenatal care, be able to bond with each other and develop a prenatal curriculum that centers them and their needs and how they wanted to move through their pregnancy as a core component. So mind you, I said that the preterm birth rate was 19%, 1 in 5 delivered early if you're black and 1 in 10 if you're white. After our initial cohort in a preliminary study of 50 women, 0 black women delivered early. Just as important, 0 white women delivered early. And so from a targeted universal approach where you address the needs of those most impacted, you end up benefiting all those who are having a shared experience. That's the kind of intelligence that we need to understand from community. And not only, the most important part of this, if you go back to structure, not only co-creating like they did in Peru, but we also shared governance in decision-making. So along the journey of how we designed the study to how we implemented it, it was shared with patients and partners and academicians and researchers at the table. And if the patient said no, it was a no. That's dangerous, right? We're trying to figure out how to co-create, but then how do you co-make decisions? How do you share power? Those results yielded the outcome that benefit everyone at the table, not just the researchers, not just the providers, but most importantly, those who are most impacted. And then we've gone one step further. So the training and the implementation of the model are now led by these same women. We have this model of patient turned partner. So they walk alongside the researchers in the educational model and framework for how do we co-develop and continue to iteratively improve the model so that we reach everyone who deserves it. And thereby, to your point, gave us the opportunity to work with policymakers, of which we were now able to launch enhanced reimbursement for the model. And now we at the IHN are positioned to continue to train and educate provider organizations and policymakers and academicians how to replicate this. How do you really share power, share governance, share decision-making, and radically listen to the needs of those who you are serving and address those who are most impacted to really shape and close gaps and inequities. And I will say for your countries and where you reside, is the data disaggregated at a level, even if it's a homogeneous sort of population, are there differences by geography, by economic class? Are you truly reaching all those who are most impacted, thereby lifting up everyone within your community?
Thank you so much, Dr. Jolly. What a terrific example of just a hands-on partnership that you've been able to develop and the effects that you're starting to see. Dr. Figueras, what can we learn from your position? You know, you seem to be roving around Europe, making positive change, stopping negative reforms. I thought that was a very important point, trying to kibosh those. What can we learn from that? Please share some of your recommendations also for the direction of the research field.
Yes, where do we go now? First, thanks again for the opportunity to be back here and for what's been a great conference. I had sort of 4 sets of reflections. I timed myself not to go too far. Echoing very much what I heard from you, Professor Kruk, actually, and from many of you, and how we take those forward. The first one, which is hardly original, but very important, is why don't you help us to make a better case for health systems investment? It's nothing new, I know. But let's reflect a tiny bit on that. Let me go back to my favorite tale. I already mentioned it once, I think. my fairy tale, Cinderella. Health Cinderella was for a bit during COVID dancing with the Minister of Finance, and now it's back in the kitchen. Ukraine, NATO, and others are taking a lot of the cake. How do we get the Minister of Finance back to the kitchen and find Cinderella to be in the palace? This is where we need your help. And to do that, there are different ways to do that. There's a line of research we've been doing, actually, Professor Greer here in the room as well, that we call is not health in all policies, not what you can do for me, but what I can do for you. Health systems are important for other SDGs. Better health, better educated kids. Better health, better productivity. Better health systems, better environment because of the of the role of the health systems actually being one of the main producers of pollution as it exists. So, but more than that, better health, better cohesion, security, stability. These are the kinds of things that may wake up our Minister of Finance to go to look for Cinderella. There's interesting research, actually, again, sorry, Scott, I mentioned you again, you and I worked on that. The impact of poor health on populism. Lower health leads to mistrust. Look, the point that Luke Allen was making, the trust on your provider. If he or she doesn't take care of you, you mistrust the system, you mistrust the whole democracy, and you become more of a populist. These are important arguments that we need to research, study, and communicate to our policy makers. Second, like you, Dean Galea, I don't see health systems and public health as different things. You may disagree with me, but that's it. So that's the way. I mean, I do believe that public health and health systems are sisters, if not the same thing. Again, COVID. I don't have to say that we're lousy during COVID in public health. We just did it very badly. No one listened to us. Sorry. So what have we learned out of that? We have now a second bite at the apple. Migration. Our arguments, our evidence about actually migrants are not that unhealthy, are not that expensive to treat. I'm taking only the bit on the health system, by the way, not the other elements. Vaccination. Environment. I was leading a conference on health systems environment in Barcelona. Everyone agreed we heard data over our noses, over our heads on the subject. We're not making much of a difference. So one approach here to be more practical is what we call public health diplomacy. Actually, the Association of Schools of Public Health in the US and in Europe came together in this kind of initiative. Actually, not far from here, Professor Ashish Joshi, the Dean of Memphis, School of Public Health, we've been working on this idea of public health diplomacy labs. We've been working on this idea to develop communication mechanisms, tools, training our own public health people and health systems people to be able to then work with our actual diplomats, our policy makers, with a small p and big P, particularly at local level, to empower them with those kinds of elements. And we ourselves in public health should be visible, should be in TikTok, among others. I'm not getting into buying TikTok or not, but among others, into the kind of debates from a public health perspective. We believe in health, right? What is health in all that? 3, very quickly. Again from you, Margaret. Measuring 4. And I really enjoyed sort of a lot of the work today that I heard. I mean, the People Voice survey, amazing stuff, the Iconic project, so many other projects. And the next step is, number 1, should we benchmark, name and shame? I know we don't like to do that, but maybe it sometimes helps. Should we go on benchmarking and learn how to do better benchmarking? But secondly, measurement 4. I am missing what those differences in performance mean in terms of policy implementations and policy changes. When you put a policymaker in a ranking or in a performance, you have to be able to say, and now let's work together, as you do in your high-quality systems framework, health systems framework, as we do with the health system performance assessment framework, and try to build this data, these benchmarks, into actually storylines, storytelling, and helping this policymaker. I know I've seen lots of experiences these days of doing that as well, but if we talk about the future, I like us to do much more of the measurement for that Professor Crook has been saying several times in this conference. And finally, surprise, surprise, and again, I'm aligning here with all of you, in this case with Patty as well, Patty Dr. Kaseya, about the transformation and about the need to have more, said that yesterday at NAUSUM, I apologize, but having much more scientists getting into knowledge brokering, and also transforming all this implementation research, the Galea you're talking about, into actual tools we can do. I thought the BIT example yesterday about transforming some of that, those tools, those implementation research on tools that you can actually use. The banks, the bilaterals, the ministries are thirsty for those kinds of tools and mechanisms where that implementation science, what does implementation science means for Monday morning? What do I do Monday morning with my reform? Please help me with tools and mechanisms, translate that much more. I'll stop here. My time is telling me to stop.
Thank you so much. Well, I sit here and I reflect, and from all of you, I was hoping for maybe a slightly simpler answer, like say, money and drugs, but I'm not hearing that. And indeed, I am hearing about a lot of complexity. And I think our task, though, as we release these lovely folks back to their day jobs and their lives, and most importantly, their research and the shaping of the scientific agenda, is how do we start? Where do we start in a positive fashion with transformation and health improvement in mind? So let me ask a few questions that reflect some of the things I am hearing, and ask for those of you, we won't go right across, but if you would like to comment, I would love to hear from you. So the first thing is, and again, a major theme of this conference, is the power and the value of comparison. We don't have to recycle failure. We're not doomed to that, if only we looked around. And yet, Dr. Galea is telling us, well, maybe there's nativism, or the way I think about it is national pride that stops us from looking outside, from or thinking that we're very different. I don't know how many times since moving to this city, St. Louis, I've been told it's the Midwest, but it's not like the other Midwest you might know. It's very special. It's very different from everybody else. So we do have this this pride, this local identity, which is so essential for systems to function well. So actually what I want to hear from each of you about is, what is the political economy of comparison? How do we defang it? How do we make it less threatening and therefore more useful? So who would like to get us started? If I see you reaching for the microphone, go for it.
I'm in love with microphones. No. I think that's a beautiful question, and one that centered my life for many years. The first thing, there are many, many ways to do better comparisons. The first thing, you try to choose those countries, those situations, those states that are similarly to use, so that you respect. Even if there's not best practice, you have to go into what I was trying to say yesterday, the tacit knowledge, tacit understanding of your policymakers. That's number one. Number two is about, as I was saying earlier, to link those performance indicators with actual things to do about it. Just don't leave them with the data, but leave them and where they are, but with the specific interventions. Number three, show longitudinality, show change within the system. So compare with the others, but show what's possible. The other day, I was in a country whose name I need to forget, presenting to the whole country with a minister there. This country has the worst performance indicators of the whole of Europe. And the minister ended up happy. I'm not trying to say I'm a great communicator, that's not the point. The point was that I was trying to point out those areas where he made real progress. I was trying to point out that there was a ceiling as to how much more performance can you get out of your resources. I was trying to help the minister to say, let's go back to your prime minister and say, at this level of percentage of GDP, you better close down because there's nothing you can actually do with the current expectations of your population. So it's this political contextual understanding of performance, not just be a bully. Earlier I said, you know, naming and shaming, just to provoke you, but don't name and shame. Name, but not shame. Don't bully, don't provoke. Context, sensitivity. I'll stop here.
Wonderful. Dean Clare.
So Dr. Figueres has said a couple of things which I agree with strongly. Let me try to build on that. I guess I start from a very simple level. What do I want from my health system? I want the best doctor in the world, as close to where I live as possible, available to me anytime I need them, with the best drugs and the best diagnostics and intervention possible, all very close to me and all available to me at all times. That's what I want. I think that's what we all want. That's what humans all over the planet want. So that's that. None of us are going to get that. So the question is, what's the gap between that and what we can actually have, right? So in terms of thinking about that gap, I think two things. Number one is the science that says, what can we have and how can we bring it as close as possible to what we want? But then, what are the values, the norms, the trade-offs we're willing to make to close that gap? And I feel like in science, our role, I've always felt this, our role is twofold. Number one is to generate the science that says, in this particular case, what we can have as close as possible to what we want. But number two is to help guide the social conversation about what is acceptable to us. What are the values about the trade-offs we make? Maybe we can have the best physician, but the worst drugs. I'm obviously oversimplifying here. But that is a sophisticated and difficult conversation, and Margaret used the term the political economy, that I think is influenced by the world around us. And it's very hard, and it's very messy, because not only is it difficult and messy, it is also used cynically by partisan actors. So our job is to try to find a place through that thicket. And Dr. Figueres made the point, which is actually comes from some data which I often use in my presentation, about places with poor health are much more likely to vote for populist leaders. And this has now been established in this continent, in the European continent. And to my mind, what that speaks to is the universality of health, how much that matters to us as a value, and how much we are willing to countenance totally shredding everything else if we feel like we're not getting it. So our role is in science is twofold. Number one is do the best possible science to identify what the thing in health systems we can have is that is close as possible to what we might want. And number two is to be useful guides, useful translators, useful partners to societies to make the decisions about the trade-offs, what we're willing to invest, what we're not willing to invest, to allow societies to settle comfortably on what they can have.
So I'm really appreciating this connection, just this last point that I'm hearing, because I think the notion of the, it's not just translator, right? It is someone who understands what society is valuing and is able to make the argument for that based on the science. And it really strikes me that it's very closely linked to your concept of the tacit knowledge. You should know what is preoccupying the policymakers, the communities at this time, the population, which is why we do the People's Voice Survey. What is on their minds? What is stressing them? And then make sure that that science speaks to those concerns to be heard. So I appreciate that. Let me turn to this side of the panel, and maybe Dr. Garcia, tell us about comparison. Was that something that was useful in your role as minister in Peru? What worked, what didn't?
Yeah. So. And maybe bringing an example also. I think comparisons are good, are quite important, but the context is critical. So, and it will depend on the situation, to whom you are comparing, and how you present the data. And I'm kind of saying the same thing as Joseph in a different way. In the case of, and I'm going to bring a clear example, the PBS, okay, the data from the PBS of the People's Voice Survey, okay? We had the data from Peru, from Argentina, from Uruguay. And when we were discussing this with the different countries, okay, we found different context and different ways in which countries will take it, okay? For the case of Peru, the first question was from the politicians, okay? and we had the Minister of Health, the vice ministers, and everybody there. How are we in comparison with the rest of the countries in Latin America? And actually, I was really, really concerned because we were the worst as Peru regarding the data. And so in the context, I mean, when let's present you the data, okay? And then we had some data from the other countries. They're like, well, the reality is that we are really bad compared with the other countries. And the next question from the people there was like, what can we do? And that goes with what you were asking. So, and we kind of guide in that comparison the discussion of there are so many things, and probably you cannot approach all the things at the same time, but let's try to find a few ones, right? And we found, for example, that in the area of prevention, where the government was investing a lot of money, the data in prevention was really bad, okay? So people were saying that they didn't have any blood pressure taken, or nobody talked to them about, I don't know, they never had glucose and all the other things, okay? And so they choose that one. But the most important thing is that then we started to discuss how important was to have a baseline. So to have a longitudinal comparison. So that was the case of Peru. However, in advance to comparisons with other countries, okay, we learned that it was better not to present the comparisons, but to go and present the case of the country directly as a baseline. So comparisons, I think, are important, but the context where you are going to present them are critical. And the other thing that is important is to have some solutions in the back or suggestions, okay? And bring those into the table and discuss all together. So, and again, I think you use another word that is important, not to produce shame, but to think about, again, so replace the S of shame, right? Shame with an S, with solutions, right? And see this as an opportunity, because you are measuring a baseline and you have the opportunity of measuring again. So I think, and in my own experience, I mean, I always like to measure, but because if you don't measure, you cannot improve. And that's another thing that we were trying to push. If you really want to improve, you need to measure.
So this is wonderful because it really links up to this notion that this isn't a one-time thing. If we show these data the one time, it's extremely difficult to derive true insight. And the other point I think that I just want to emphasize that I'm hearing across several of these comments is that we are, that even low performance can be turned into an opportunity, right? We often complain about, I think we've heard in this conference, the lack of headroom. I think we heard from Dr. Figueroa, the US is already doing well in these particular dimensions. It's actually quite difficult to have the next percentage change happen. But what I'm hearing from both of you is, whether it's in Peru, whether it's in the unnamed European country, that low performance is an opportunity to demonstrate a positive change, to demonstrate success for that political system, for that committed Minister of Health. So making that seem, as we are trying to do in this whole conference, that this adverse information is an opportunity for improvement as well. Dr. Jolie, do you have examples you can share about how comparison could work with communities?
Yeah, as interesting. This is the question I answered last when you sent them out, because it is, I think, the hardest one to tackle, in part because of something I'm reminded by at your first presentation about the impacts of health outcomes, and I think the bar was about 40% were structural and socioeconomic and external factors. And so there's a lot of work being done here. What is the work we're going to do, as Dr. Kaseya mentioned, to transform ourselves as researchers or as policymakers or government officials in a way that represents the community you serve? In our country, our leaders, our politicians do not reflect the broader community that they're responsible for, in a way, demographically. And so if you were to disaggregate that 40% or so, it's a different experience for someone that looks like me here in the context of the United States. And so the question is, how through grassroots level advocacy or grassroots radical listening to the patients you serve, and then how do you allow that to transform yourselves in a way that you can influence policymakers and other researchers in a way that closes gaps and inequities, but overall really address the needs of community. And when I was traveling, I did an Eisenhower Fellowship. I had the privilege of traveling to Rwanda and Australia to compare their health systems. I'm reminded by one of my mentors who said, if we all speak the language of the patient, then we should all be able to communicate.
That's fabulous. And of course, one of the themes and one of the key motivations for the work of your network is disparities, which are in themselves a comparison, right? I mean, that right there is telling us what is possible in our own community, right, in our own health system for some people, and therefore why not for all people? I think that is an important point. I want to shift gears a little bit and think about this connection between health systems research and public health and population health science, because it is undeniable that we are a very small part of that pie, of that graphic. And yet, as Dean Galea said, even the most, in the best public health system and the best systems for health, people will get sick. And we still count and need those institutions that we're working on. So what is it we need to do differently as we think ahead to health system scholarship? I mentioned at the very beginning of this meeting that one of the observations motivating this meeting was that economists are 80% of the people in the room typically when we talk about health systems, and that is with great respect. They have a lot to say and a lot to add, and they've been critical in really quantifying some things that are difficult to quantify. So an essential component, for sure, but not the only one, right? And so we've been trying, and in this meeting also attempting to bring in these other disciplines. Is it political science or engineering? Systems design and clinical science, most importantly, to the table. But I guess I would ask all of you, what is missing? How do we, because remember, we still need to be focused on our research, our methods. We can't do everything. We're not multi-talented and multi-capable. So who needs to be in the conversation on health system science, health system performance? And how do we, very practically, build those connections? Because sometimes we are speaking somewhat different languages. And I guess I would start with you, Dean Galea, because this would seem pertinent to the School of Public Health.
Yeah, I'm not sure I have the answer, but I do have multiple aspects of the problem. Just this morning at the somewhat unfortunate time of 7 o'clock in this morning, I was part of the WHO launch of their new urban health strategy. And this has been 2 years in the making. There's been a writing group which I've been a part of that developed a strategy about health in cities. We all know the world is more and more urbanized. By 2030, we'll have about 60% of the world is urban. By 2050, it'll be about 70%. And it's a good comprehensive strategy, and it never addresses health systems at all. It talks all about the multiple sectors, talks about economics, talks about politics, talks about urban development. And the entire strategy is about how we generate a world that keeps populations healthy and really then has a blind spot to what might happen if people need health systems. So it struck me, just because it was this morning and happened to be sort of in the middle of this meeting, how different these worlds are. So that's part of the problem. So then in terms of how you bring them together, I think I lean onto the only two things I know how to do, which is, number one, is to do science and scholarship that illuminates how these forces come together to shape the health of populations. And number two is to try to be part of the conversation that creates the intellectual frameworks that we collectively, as a scientific community, can use to ground our work and then to help inform societies as they make decisions. So I think the very fact of having this conversation should set the stage for all the scholars in the room to think about doing scholarship that grounds health systems, for example, in urban context, just because it's fresh on my mind from this morning, to think about what is it about growing cities and how they influence our health and how we can integrate the science and scholarship of health systems thinking within that. And B, how we as a collective health ecosystem make the effort to generate and shift the ideas about health systems being inextricably linked to the context within which the health of population is generated and not as their own island.
Yeah, that's a terrific example, and particularly in light of the keynote we had from Dr. Kurth, if you remember, who is tasked and is thinking day in and day out about healthy aging in an urban context. So presumably this report will be extremely relevant to her, and yet a lot of her focus is on health systems. So it's interesting to me that focus in a huge city, in a big country like this, didn't really penetrate this report. So what I'm also hearing from you, I think often we in health systems research, I think rightly should take the rap for not reaching out to enough disciplines and not bringing those into some of the conversations. But I'm also hearing that in the population health space, that needs to be expanded as well. Those invitations and those openings need to go both ways. So that also for us to learn, about these broader determinants. They certainly show up in the clinic every single day, whether we know them or not, and whether we understand them or not. So it behooves us to get that right. Others who would want to comment, please, on this notion of how do we meaningfully, without diluting, we've got our scholarship to focus on, but it's very, very clear that systems function as social institutions, as political institutions. They're highly politically inflected. I'm looking again at you, Patty, and not to put poor Peru on the spot, but Dr. Kaseya is right. Peru's had some of the worst ratings of the health system. And when we wrote these papers and looked comparatively, one of your explanations was the politics are really tough in the country. The Minister of Health has changed over 4, 5, 6 times in the last year. So more. Okay, Patty, over to you. And how do we, within the science of systems, how do we meaningfully incorporate, for instance, the political environment?
Well, if you read the news, probably you have heard that we just recently changed president also. And that, and we are only less than 5 months from having new elections. And actually, since the time that I was minister, which was in 2017, we have had, I think, almost 20 ministers of health. So those kind of situations are critical. But I think that I understood your question. I mean, who else should we bring into the game, right? When we are going to do this type of research, if we want this to be meaningful. So I think we need to try to bring also policymakers, okay? And we need to hear what they have to say about this. I also think that we need to be very conscious that when we talk about health systems research, of course, we're talking about the highest level, but we need to include all other different disciplines, okay? We're talking about mixed methods, qualitative research. We have been talking about implementation research, and maybe we should be talking also about other new disciplines like program science, because they all together, although they work at smaller levels, I mean, they all together at the end are going to allow us to understand better how health systems work. So I think including policymakers is going to be critical. We have some tools that allowed us to hear what people had to say, but I think community, it's another component that might be important to try to understand and to work better. We have been talking about co-creation, and the co-creation has to do with involving them too.
That's a theme I think you both expressed very articulately. Dr. Higueras, would you like to comment?
Yes, very, very briefly. I mean, no rocket science, multidisciplinarity, multi-actors. I totally agree, very good points, Patty. Let me talk a bit more about the actors. What other actors? NGOs, civil society. I learned over the years that when the minister goes, everyone goes with the ministry in some systems, even the porter. So the whole ministry gets empty. And it is civil society that reminds the country of the kinds of commitments that they've been doing. That kind of transparency and accountability of civil society is important, and we don't know how to work with civil society very well. Trujillo, I mean, you've been talking, and I totally agree about patients. We love to talk about patients, and exception to the points you are making, often is a lot of rhetoric. why don't we do some more research about how do you really involve a patient into making decisions? I've been doing this kind of work for many years, both in representing the patients in hospital boards, in health systems. Usually they are sort of ignored, or at the bedside table, as it were. We keep talking about that. We keep talking about empowerment. But I want to hear more of the kinds of Dr. Jolly's presentations, points today, about what mechanisms, how do you consult a patient about his or her possible outcomes and different options, how you bring them on board. So there's a lot of rhetoric around that, but very few mechanisms. These are the agents, the professions. Do you know that there are two professions that are particularly influential in making decisions? Have you checked the specialties that work with as ministers of health? Cardiologists, very important. I now work very closely with the European Society of Cardiology. They're extremely important in policy. Why? And neurologists. I don't want to get there. It has to do with men in power. So these two professions, sorry about this basic joke, but it is true. These two basic professions play an important role. Why don't we work with doctors much more in decision making? And then disciplinarity, and I stop here because I'm going over the top. Multidisciplinarity, Margaret. It is not true that we are multidisciplinary. It's not true. We are very incestuous. I want to see not only sort of economists and political science, I want to see psychologists, behavioral psychology. Right now in the country where we are is very useful. And in my countries as well, all over, behavioral psychology, because otherwise we don't understand what's going on in politics, neither in small politics. So, I mean, I'm in a key of a stand-up comedy today, but the point being, there are very serious points behind those things that we need to understand and we keep ignoring. And there's serious research and mechanisms to do that we should be undertaking.
Margaret,
yes,
may I say
please.
one
Please.
small comment? I mean, I completely agree. I would call it professional societies. And actually, professional societies can be critical, can be barriers. I mean, we have professional societies, for example, I have to say, like gynecologists, that have become really barriers, for example, to work on the introduction of self-sampling for HPV testing, because that involves, they want to do it. And of course, we are affecting their economy. And I had a big fight as a minister of health. So, but I learned also that we have the good ones, so we have the bad ones, we have the people in the middle that you can move into the bright side, and you have the good ones. So I think professional societies can be critical to move the gauge when you want to make changes, when you want to involve community health agents, when you want to do things, innovative things that could make things work. So I agree completely with you. We have missed them, and they are critical. They could be really facilitators, or they can be barriers, and so we cannot ignore them. Sorry.
Either way, they have a loud voice, is your point. Dr. Jolie.
Yeah, I think you said it. The disciplines missing is behavioral psychology, leadership development, and because you mentioned just from a provider or a health system listening to the patient, they don't even listen within themselves. I used to be an administrator running an allergy department, and there was a patient that had an allergic reaction to a cardiac drug, and the cardiologist refused to defer to the allergist because they're a cardiologist until the patient almost died. And then, I need your help, the allergist. And then you go down a step further. How do you defer judgment and power and decision-making with somebody who has no degrees? Or they may have degrees, but they're not in your profession. And that's why I began with radically listening. For our providers in the model we talked about for group prenatal care, they had to defer judgment. They had to listen and absorb and recognize these patients had expertise, and then thereby they solved the problem. They then developed a question. Oftentimes it is us who are in positions of power to understand we have the ability to transform ourselves, but that's not necessarily innate. That is a learned skill. And so in part of that, behavioral psychology, medical anthropologists, historians, these are other tangential expertise that are often missing in the room that can help guide us as designers and collaborators and partners.
Fabulous. So we're nearing the end, so I'm going to prepare you all for a lightning round. So Sandro raised the issue of the vulnerable human. And the way I've always thought about the vulnerable human at the center of the health system equation is that that's all the more reason why health systems have to up their game, because we are dealing with people who are at their most vulnerable coming forward. And so when we think about quality, we got to get it right. We got to get it right from a technical standpoint and also from a human standpoint. So there's no question, that is the whole premise of the business, is helping folks who are at that moment vulnerable. And what I want to posit is, again, drawing on Dr. Kaseya's comments and many of the themes that have come up through the meeting. We have AI, we have technology. Folks aren't going to their doctor first, they're checking on their symptoms first. They're keeping that information maybe in their heads, or maybe they're speaking it to their clinician, but either way, it's changing fast. And so my question to you, lightning round, and you're allowed a yes or no and a but, if you like, is AI going to equal the playing field or level the playing field, reduce some of the vulnerability of the patient when they approach the health system? Patty, let's start with you.
No. You want to say yes or
You can
no?
you can say no, but remember, we have to be positive, Patty. So
So I'm still concerned about AI and the breach that still exists about the data, especially from low middle income countries, to be able to really serve the people that they are supposed to serve. Okay, so I think it's a great tool. I think technology in general can help us to catalyze changes in health systems, but we have to use it in the right way. So that's why, I mean, that's why I say a no, and especially coming from a low middle income country. I'm still scared about inequities that may cause, especially because we still have populations that they don't speak Spanish. They may not be able to read, or, I mean, and there might be information about these communities that has not been entered into this machine.
the training algorithm.
Yeah,
right.
the training algorithms are not including native communities, Quechuas, Aymaras, or whatever. So I think there is a gap. There is an opportunity, but at this point, I think we have to be careful. I mean, it's a lot that we still have to learn.
Thank you. Perfect. Dr. Jolly.
I think my answer will be no, for the reason until systems and structures are changed, until the minds and hearts of those who are in power will have control. AI is a tool. It's not a solution.
Okay, thank you. Dr. Figueres.
Well, I need to disagree by principle, so just to change a bit. It depends, and it doesn't matter.
He's writing his own response options.
It depends, exactly as has been said already, if we are able to regulate it, if we are able to steer it in a way that is not biased, it doesn't increase vulnerability. However, the potential of transparency, the potential of accountability, the potential of empowerment is there, and we should not ignore it. Look at how mobile technology in the South is revolutionized. Health is there, everyone has it. But nothing matters because it's there, it's going to move. So it doesn't matter, we're not regulating it. Your president says, let it go. So let's make the best of it.
Thank you. Dingle.
Well, recognizing first that nothing will shape cardiology's hold on the world's imagination, I think the answer is yes. I actually think yes, with the caveat that it will take time. I think there's no question that, like all the rollouts of transformative technology, there are gaps. I think we will see a widening of access gaps and utility gaps of new technology like AI before we see narrowing. But in time, these new technologies, unless they kill us, end up improving. Actually, they end up improving our collective standard of living. I mean, I was actually going to say Dr. Figueres' example. Like, I mean, mobile telephones are the perfect example. I mean, the number of ways in which cell phone technology has become simply part of healthcare delivery throughout the world is countless. I mean, there are many people in this room who were old enough to remember when mHealth was a thing. Remember that? M Health. I mean, some large foundations that remain unnamed, M Health was their center thing. That's how new it was. That wasn't that long ago. That was like 20, 25 years ago. So I do think AI is going to be transformative in health systems everywhere, but I also think it's going to take 20, 25 years.
Right, and that's enough time for us to shape it, folks, in this room. So please join me for a rousing round of applause for this incredible panel. Okay, thank you. And back to you, Todd.
Wow, what a great way to end our sessions at this conference. Now, for some closing remarks, I would like to invite Executive Vice Provost Dr. Mary McKay to the podium. The mission of Dr. McKay's role is to collaborate with all vice provosts and senior administrative leaders at WashU to align activities, resources, and efforts towards the guiding vision of the provost and the chancellor for academic distinction. Dr. McKay joined the Brown School at Washington University in St. Louis as dean in 2016 and has authored more than 250 publications on mental and behavioral health, HIV/AIDS prevention, and urban poverty. And after Dr. McKay, we will have a farewell from Professor Crook. But first, please welcome Dr. McKay.
Well, thank you for that nice introduction. And really, this is an honor to close out your gathering. So thank you so much for inviting me to say a few words to this distinguished group. So as I tried to be as thoughtful as I possibly could about how do I close out your time together, I'm going to kind of tackle three chunks of content. I want to be sure that we appropriately acknowledge the time and the people that made up this experience over the last set of days. I want to be sure that I elevate the themes. It's important as you've gone on this journey over the last set of days, there's been a lot of things thrown at you and hopefully you've integrated them all fully. But if you haven't, some things to leave you with so that they inform your work. And finally, I loved this last panel, but so much of what I've heard in the time that I was able to come and listen in the back, I want to put forth a challenge to all of us to make these days actually matter. So first, acknowledgements. Have you noticed that Dr. Crook has thanked everybody, every panelist, and every opportunity? And it's very challenging to thank herself. And so if we could first acknowledge Dr. Crook and her team for bringing us together, I would so appreciate that. Dr. Crook, you did something that I think I just have to elevate in 2025. When I was here the first day, right before the keynote, you asked folks to raise their hands who had never been to St. Louis. And I saw 3/4 of you, not everybody's still here, raise your hand. You brought people to the middle of the US in a time that there's so much conflict around global partnerships, around our shared work together. And you actually managed to get people not to Seattle, not to Washington, DC, but Washington University in St. Louis. And my hope is that all of you that are new to this part of the country, to our city, to our region, you found that valuable. You learned something and that you take that away. And really, it's incredible leaders that actually could bring people out of their comfort zone, having you double check and triple check your plane tickets to make sure you were actually coming to the middle of the country. Thank you, Dr. Crook and the team, for really, really planning a terrific conference. Please thank Dr. Crook and her team again. I do want to also acknowledge that the institution that we work for, Washington University, I think is truly leaning in, and I'll talk to you a little bit about that in just a few minutes, around our leadership, both in our region. So if Dr. Jolly, if you are still here, that we, thanks Andwele, that we are trying to lean in as an anchor institution, as a partner in our region, national leader of really improving health, overall population health, systems health, and across the globe. And so I do actually want to acknowledge that Washington University both welcomes you, and I think we'll learn a great deal from this conference and going forward in partnership with all of you. I also want to, if Dean Galea is still in the house somewhere, you know, Dean Galea, you do many things. You've had a stellar career, but one of the things right now you are embarking on and in the midst of is one of the most ambitious things I've ever seen a university do. You're starting a school of public health in partnership with so many others. You've centered health equity. You've been here about 10 months. You're racing towards accreditation. And I think that this boldness is what all of us need. An ability to start new things even when the circumstances are not ideal. You probably couldn't have even imagined as you entertained how unideal this actually circumstance in our country might be. And yet your foot is squarely, along with so many here at Washington University, on the gas, really trying to make a school of public health and the science of population health really matter. And so I'm incredibly grateful to WashU, the leaders in this room that really are trying to make a difference with two hands behind our back and the blindfold and the whole thing that really is challenging us right now. So thank you all on my side of the university for all that you're doing within our themes today. I also want to acknowledge all of you that traveled, that shared your wisdom, that shared your methods, shared your perspective. I hope you both agreed with each other, but also disagreed with each other. We need partnerships that are fully engaged, that are bringing their talents. And I think I've seen in the snippets that I've been here, Margaret, that really on display in social hours, in evening events, as well as during the conference panels. So thank you all. Please give yourself a very strong round of applause. So let me just raise up a couple of things for your consideration as we leave this gathering. First of all, I think, you know, elevating the theme of commitment to science, informing health systems, both at home and across the globe. And I think that there's some implicit values that you embedded in this conference that I just want to raise forward so that we take them with us in a clear way. First of all, that science, we have to bring together data. We have to be willing to risk it by being innovative. We actually have to make sure that as we're innovative and as we measure things, that we also be very, very aware of the equity issues that are embedded in the science that we need to bring forward. And so I think that commitment to science, I did, Margaret, this is not my field. I've studied children's health for decades, but I actually thought health system science was a thing already. But I think you've upped the game in terms of really, really elevating this group to do really more impactful science as we go forward. So thank you very much. What's another commitment? This commitment to measurement that leads to improvement, to creating the tools we need to really seize the opportunities so that we can help people be healthy and well, I think is incredibly important. And I think that sometimes our systems, our policymakers, our partners, you know, they want to concentrate on a set of things that they wouldn't call measurement. And yet how we open up the space so that we can come together and really look at data and change and revise what we're doing, I think is really important. So you putting forward and emphasizing the methods of measurement, I think has been very important. You have also emphasized partnerships across disciplines, institutions, countries. You've talked about co-creation of solutions. And I do, Dr. Jolly, I want to say, Andwali, I want to say that the example that you gave from our region, I don't think you even did justice to the amount of work that your organization has done to elevate the voice of women and their preferences around how they'd like to be cared for. And that was hard because also the pressure on you from your funders, from your conferences that you have to present, that you have to kind of make it acceptable, a method that's acceptable, to those audiences, and also really insist that those women were your co-presenters at the conferences, co-authors on the papers, and really the architects of what they wanted to see in a healthcare system. And they maybe would disagree a little bit with Dean Galea. Did they want the best doctor and the best hospital next to them? I'm not sure. They wanted other women that shared their experiences. They wanted practitioners that actually would help them deliver safely. They wanted to live through that experience. And if it was a great doctor, that was okay, but it could be other practitioners that they may even trust better. And that being able to kind of disagree and bring their voice into this, I think really is what partnerships are all about, that are real, that are co-creating solutions together. And I know that many of you have examples of that, and sometimes in our professional language, we're not as radical representing what we've heard. And so I really, really appreciate those discussions around global partnerships. So now for the charge. First of all, let me just say to Washington University, if you're listening, I appreciate all that this institution does, and I also appreciate our attempt to up our game as a partner in our region, across the nation, bringing people like Margaret Kruk here and supporting a global conference in circumstances that might not be ideal. And so I, as one of those leaders in WashU, and many of you in this room, I just want to kind of express our real commitment to upping our game in research that really matters. And I think that you exemplify the kind of faculty that we have here, and that we need to provide more and more support so that you do your very best work. For all of you, I've had this real privilege from the Office of the Provost to kind of catalyze our 10-year strategic plan. And that 10-year strategic plan had a very important vision statement. The vision statement was around how could Washington University mobilize our research infrastructure, our faculty? How could we mobilize our educational portfolio? How could we mobilize patient care to really become a hub here in St. Louis for transformative solutions to address societal challenges? And I want to say that I'm proud of that vision statement, but I also recognize that no one institution can do that by itself. So one of our core kind of themes within our strategic plan is around global partnerships, bringing in global perspectives. I think I'm inviting all of you to join us to be even more engaged partners as we do work that really matters. And particularly, I want to take very seriously with something that Sandro and a couple of other people that I heard say across the journey. I want to take very seriously this notion of bidirectional learning. That truly we talk about bringing things from across the globe back to our region, and then we have professional societies and professional standards and all kinds of things that maybe interfere with that, but actually maybe even our own biases about who develop things and what the appropriateness of those. And I want to challenge us to actually make sure that as we're developing methods, we develop those methods for how we actually have bidirectionality in terms of how we apply our findings. And so I'm very, very committed to that, and I hope I'll be a good partner. So let me end by, Margaret, you were trying with that panel, when everyone was saying no, to nudge us towards optimism, and that's what I'm going to try to kind of close with. You spent days together. Your time is precious. Your talents are really, really impactful, and you came together. And my hope is that by coming together, by coming to a different part of the US, by navigating complicated times together, we will be more and more impactful, we'll make a bigger difference. And so